Щирі вітання університетській родині. Сьогодні ми маємо особливу честь зустрічати в Буковинському державному медичному університеті людину, чиє ім'я добре відоме далеко за межами медичної спільноти. Тож спільнота університету на чолі із ректором раді вітати відому особистість тут, на Буковині. І ми з приємністю запрошуємо до слів привітання ректора Буковинського державного медичного університету Ігоря Васильовича Геруша.
Шановний пане Генрі, шановні друзі, це велика честь, що у стінах Буковинського державного медичного університету ми маємо нагоду вітати всесвітньо відомого нейрохірурга, відомого вченого, автора бестселерів і великого друга України Генрі Марша. Знаєте, ми з ним спілкувалися, він каже, що понад 34 роки він вже приїздить в Україну. 34 роки він допомагає нашій державі. 34 роки він вчить людей. Але він вчить людей не тільки в Україні, а по всьому світі. Знаєте, я думаю, що це чудова нагода для нашого студентства, для наших молодих вчених поспілкуватися з такою величиною. Це чудова нагода побути тут і дотикнутися до величного. І це велика честь, що Генрі Марш сьогодні у нас. Dear Henry, dear our guests, it is a great honor that today we have at our university Henry Marsh, a well-known British neurosurgeon. We know you as a pioneer in neurosurgery. We know you as a great, very big friend of Ukraine. I know that for last years you are support in what time our country, our doctors, and all community of Ukraine. And Henry Marsh look like a rock star in neurosurgery, really, because he is as author of famous, well-known books, who has bestsellers all around the world. And we discussed today with Henry Marsh, and he promised every year visit Чернівці. And I think that today will be only the start point of our cooperation between Henry Marsh and between Bukovinian State Medical University. Henry Marsh, is a great pleasure to invite you to this floor. You are welcome.
Thank you very much. I'm really very happy to be here. To my embarrassment, it is my first visit to your beautiful and historic city, even though I've been coming to Ukraine for 34 years. But I'm very glad I finally arrived, and I've already been very impressed by everything I've seen. Now, let's see if this works. Yes, it is difficult to be a doctor. To be a good doctor, it is easy to be a bad doctor, of course. Now, what do I point it at? Over there? Oh, that's... There. Yeah. That's back. There. It is wonderful to be a doctor. I have no regrets for the 45 years I spent working as a doctor. I'm retired now, although I still teach and lecture all over the world. It's not just about making money. Yes, we all want to have money, we want to have nice cars and nice houses, but at the end of the day, to have work which is to be of service, to help other people, to make the world a better place, is a huge privilege. And as doctors, that is a privilege we have. And we must never forget that. You may have friends who make lots of money looking at computer screens all day, but it's really very boring at the end of the day. Medicine is never boring. It's wonderful to be a doctor. And it's an international community. I'm here speaking English, and you can understand me because your English is so much better than my Ukrainian. And if you want to travel the world as a doctor, it is something you can do because it is an international brotherhood, an international sisterhood, where in principle we all have the privilege of working together to help our fellow human beings. And we have the trust and respect of our patients. It is something we have to work to deserve. But as patients, and I speak as a patient myself with cancer, we have to trust our doctors. The idea that our doctor might not know what he or she is doing is intolerable. And it is very important that we, as doctors, work to deserve the trust that our patients must put in us. And patients are so interesting. I mean, if you're not interested in people, probably you shouldn't become a doctor. You could become a pathologist, I suppose, if you prefer your patients dead or in little bits. But what I have always found throughout my career is that other people, patients, are so interesting. And as doctors, we have extraordinary privileged access to our patients' lives. They'll tell us things they'll not tell anybody else. And we will see people from all the stages of society, rich people, poor people, middle-class people, we see them all. And that is unique. There is no other job like that. And you'll learn, as the years go by, you will learn so much about human life and what is really important in human life. It takes many years. When we are students, when we are young doctors, our lives are dominated by the need to learn so much information, to learn so many skills. But once you have learnt those skills, once you've learnt the information you need to know, what then becomes so profoundly interesting and important is the lives of our patients and what they teach us. You'll go on learning throughout your careers about human life if you listen to your patients and treat them as your equals, not as your sort of subjects. And there are, of course, many, many kinds of medicine. There is surgery, and then there are all the different kinds of surgery, the same for internal medicine, and there's psychiatry and public health. It's very unlikely you will not find some niche, some corner of medicine which suits you. When I became a doctor, I wanted to be a surgeon, but once I finished at medical school, I didn't really like general surgery very much. This is now 50 years ago, and it was big incisions and blood and body fluids and smells. I didn't like it. And then almost by chance, I came across brain surgery. And I knew immediately that was what I wanted to do. It fitted me perfectly. And although it is a hard life to be a brain surgeon, I have no regrets. I was very lucky to have had the career that I had. But why is it difficult? Why am I saying it's wonderful? But if it's so wonderful, why is it difficult? Well, there are several reasons why it's difficult. Firstly, there is so much to learn, particularly in the early years of your careers. There's a huge amount of information, many difficult technical skills, which takes years to learn. And again, it depends where you are. If you work in a good hospital, a good department, you will learn more quickly. And if you do not work in a good one, it can be very difficult. And you'll see people who are in pain, who are frightened and anxious, who are dying. You'll see death. You'll see patients who are disabled. In my specialty, I saw many people with damaged brains. And you'll see people who are depressed and unhappy. And you have to somehow push that away from yourself a little bit, or you'll become depressed and anxious and unhappy, seeing so much human misery. But not to lose your humanity and care in the process. And these patients, your patients, desperately want us to help them. And the problem with that is that we cannot always help our patients. There are conditions we cannot treat, and sometimes even worse, we make mistakes, which I will talk about, and we then suffer as well because we feel so bad about the fact we have failed our patient. And you, as doctors, will certainly make mistakes. You will certainly sometimes fail patients, and that is one of the difficult aspects of being a doctor. But if every operation, if every medical treatment was easy and never went wrong, there'd be nothing special about being a doctor. It'd be like being a car mechanic. You put a new spare part in, something like that. It is the fact medicine is uncertain, the fact medicine is dangerous, that makes it so special, so difficult, but at the same time so rewarding and so wonderful and unique. And another problem, you'll have difficult colleagues. Looking back on my career, on the whole, I was lucky, but doctors often are not very good at cooperating together. And again, looking back on my career, once I'd learnt how to operate, the technical side, the operating, the knowledge was easy. The difficult things were decision-making, getting on well with patients and their families, especially if things are going badly, and getting on well with colleagues. These are the difficult problems. It sounds silly, but the actual brain surgery, in comparison, in some ways, was easy. And probably you'll have to work very long hours. My generation, when I was a young doctor, I worked almost all week, all night, all the time. That has changed now in Europe because of laws and regulations. What it is like in Ukraine at the moment, I'm not sure, and obviously the war is complicating everything. A short story, that's a child with a benign brain tumor, and I operated just before the pandemic. I was helping my colleagues in Olika Hospital, in Olika Street Hospital in Lviv. It was an operation they had not done before. They had been given a new microscope by a Canadian charitable donor, and the operation was a great success. And it is wonderful to stand around the cot, the bed of a child whose life you have saved, with a tumor which is not cancerous. And also I was teaching and training my colleagues how to do the operation. So I felt very pleased with myself, and I thought, this is wonderful. But the next child I operated on suffered a terrible hemorrhage after the operation, and she died. She died very badly, paralyzed on a ventilator. And that happened because I'd been so pleased with the first operation, I had not really thought carefully about what the post-operative care would be like. The operation went fine, but the post-operative care, particularly with brain surgery, is just as important as the operation itself. And I was too pleased with myself, and I did not ask any questions. I did not want to embarrass my colleagues by saying, look, what is the post-operative care going to be like? I thought it would be okay because the other child was fine. But it turned out the child had not been given proper pain control, her blood pressure went up, and that is why she had a hemorrhage and died. So that was a terrible mistake, even though the operation went all right. The moral of the story is, first of all, we all make mistakes, and secondly, modern medicine, whether it's surgery or medicine or anything, is about teamwork. It's not about one big man or one big woman doing very clever operations. It is about working as a team, and all the members of the team, starting with the cleaners who keep the hospital clean, with the instrument curators who make sure the instruments are clean and sterilized, are all just as important as the doctors. And that's an important point you must never forget. There I am as a young doctor, many years ago, I think that was 1980, and then as an older, wiser man. So looking back on my career, what would I want to tell my younger self now, and what should I tell you as the doctors of the future? And may I say, the future of Ukraine is all about you. I salute you for having stayed, having not run away like many other people, because Ukraine needs all the young people it has to stay and continue to fight and work for a free and dignified country. Well, it seems to me, looking back on my career, it was like being on a tightrope, balancing, often having to fight between conflicting needs. And if you know B.B. King, the great American singer, he sang a song, "You better not look down if you want to keep on flying." If you're on a tightrope, you don't really want to look down too much, or you might lose your balance and fall off. And some of these difficult problems I faced, I didn't really understand until I'd left the tightrope and I'd retired from clinical work and treating patients. And there's a list I'll give you of where, looking back in my career, where I made most mistakes, where I found things most difficult. As I said, it sounds strange, but many senior surgeons would tell you the operating is easy compared to everything else. So what were these other problems? Well, firstly, as I've already suggested, finding a balance between caring for your patients, compassion, we could call it in English, some people call it empathy, and being cold and detached and scientific. And that's a very difficult balance to find. If you become too involved with patients, if you care too much for them, it makes the work very difficult. You'll not make good decisions. And if you become too cold, too detached, and you treat the patients like nothing, as though if you don't care for them, you will not be a good doctor. And then you have to find a balance between being an ambitious, thrusting individual, an egotist, as I certainly was when I was a young doctor, and being a good member of the team. Because as I said, good medicine is all about teamwork. And you have to find a balance sometimes between your conscience about what is good for the patient in front of you and what is good for the hospital, what is good for the department. You'll certainly find at some point in future in your careers, you will have colleagues, doctors, who are not very good. You would not really want them to treat members of your family. We all have to face that problem sometimes. And it's very difficult if you start kicking up a fuss, denouncing your colleagues. Sometimes it does more harm than good. It can be very, very difficult, because not all doctors are good, inevitably. And if you're in doing private work as well, you have to find a balance between, is my work as a doctor a vocation, as we call it in English, or is it a way of making money? And you must not allow making money to distort your decision-making. If you know that you're going to make a lot of money, say from doing an operation on a patient, even unconsciously, it'll damage your decision-making. You will probably overestimate the danger of doing nothing, and often in medicine it is better to do nothing than treat the patient, and you'll underestimate the risks of an operation. All operations are dangerous. All operations have risks, and you always have to balance the risk of the operation against the risk of not operating. And sometimes that's very difficult to do because we do not have all the information available, and I'll discuss that later in a moment. We have to be self-confident if you're any medicine, particularly as a surgeon. When you walk into the operating theatre, you have to believe in yourself. You must not be shaking and anxious, but at the same time, you must be always endlessly self-critical, because it is easy to make mistakes. And if we trust ourselves too much, if we trust ourselves as much as our poor patients trust us, we will make some bad mistakes. And I certainly have made some mistakes like that over the years. So it's a balance between high self-confidence and high self-criticism. And there is a solution to that problem to some extent, as I'll discuss later. Patients want hope, even when there isn't very much hope. Hope is one of our most important drugs. It is amazing what people will cope with if they hope they will get better. It is amazing how it's called the placebo effect. The way we talk to patients, giving them hope, even a little bit of hope, is a very important part of how we should treat patients. And sometimes it can be very difficult. Sometimes we have to lie a little bit, pretend a little bit, in order to help the patient cope with some terrible problem. If you just say, oh, well, you have a malignant brain tumor, go away and die, well, it's true, there's nothing to be done, but you're not a very good doctor. And if you do, as I did, very dangerous operations, are you being brave or are you being stupid and reckless? And it can be very difficult, again, to find that balance. If you don't do difficult operations, how will you ever get any better? So you have to take risks, but they have to be careful, calculated risks. And finally, certainly my generation, I don't know about doctors in Ukraine now, with the exception of the people at the front, we have to find a balance between work and our life. Our families want us to be 100% devoted to them, but our patients want us to be 100% devoted to them as well. I'm afraid I was more devoted to my work than to my family, and although I am lucky I have a good relationship with my children now and my 4 grandchildren, I always put work first. Perhaps I had some choice in that, perhaps not. But looking back on it, I regret it. It has changed in England now. My colleagues in my hospital do not have to work the very, very long hours that I used to work. That's a famous picture of a doctor, a 19th century picture, and he's looking at a very sick child. You can see in the background just there is an anxious parent. I did pediatric work for many years, and what's really difficult about pediatric work is not the children, it's the anxious parents. Believe you me, there's nothing more anxious than an anxious parent, and that is something we all have to learn to respect and deal with. And is that doctor, is he showing compassion, empathy, cold observation, scientific detachment? I don't know. But, as I said, this is a critical part of being a good doctor, is to find that balance where you have not lost your humanity, you still care deeply for your patients, but you don't get too upset when they suffer or things are going badly. So you must always be kind, but that's moved a bit over. What's happened? Can we move what's happened to the projector? Oh, right, thank you. But as I said, we must always be kind to patients, but not if it's going to actually distort our judgment. Sometimes I had to make decisions whether it was worth operating a second time or a third time for a tumor that was slowly growing back. And some of these patients I'd been looking after for many years, and they were really almost personal friends. And I can think of at least 2 patients where I should have said, it is time to die, which is very difficult. And I didn't, and I operated again and simply made things worse. So again, being very kind to patients, sometimes you can end up making the wrong decision. So as I said before, you must find a balance between what in English we called clinical detachment and being kind. And as I said before, again, you'll see much pain, death, suffering, and unhappiness. And you have to be detached from it. You have to observe it without it letting get to you. It all changes when you become a patient yourself. I was diagnosed with serious cancer 6 years ago. And although I had been dealing with patients all my professional life with cancer, it felt profoundly different when it affected me. So it's difficult. Now, teamwork. Every morning in my department at St. George's Hospital in London, we meet most of the senior doctors and all the junior doctors, and we discuss cases. We discuss the emergency admissions, we make jokes, we look at brain scans, and for 1 hour we work as a friendly team to improve teamwork and to learn from each other. It's very unusual in English surgical departments to have such meetings, and it is very, very popular. All the many surgeons I have trained over the years all say the morning meeting, as it's called, was a really important part of their training and their learning. So if you can establish that in medical departments, it's a good thing. You need to be ambitious to succeed. I did not become a famous neurosurgeon by not being ambitious. I've always been very ambitious. Now that I'm old, I can pretend I'm not, but I've always been a deeply ambitious person. But you also have to recognize, as I said, that you cannot practice good medicine if you don't treat the team well, if you're not a good team member. In the past, perhaps it was more possible. Professors and senior surgeons 50 or 60 years ago in England were godlike. Nobody ever questioned their judgment. But all that's changed now. You cannot go around bullying and shouting and being dictatorial. And I think that's a change for the better. Good modern medicine is all about teamwork. And this is the first important fact I want you all to remember. Very simple fact. And that is, other people are better at seeing my mistakes than I am. And I am better at seeing their mistakes than they are. That is because we all have a built-in optimism bias. We all think we are better than we really are. And we need that to some extent. As I said, as doctors, particularly perhaps as surgeons, we need to have high self-confidence. But it can be very dangerous and very damaging. We need other people to criticize us. We need other people to point out our mistakes. That is a brain scan showing what is called a Chiari malformation. Is there a thing here? The cerebellar tonsils are lower down than they should be. It is a benign condition. It's not dangerous, but it can cause severe headaches. And the operation is to fix that. You enlarge the foramen magnum at the base of the skull. It's technically a simple operation. When I saw that patient, this is now about 20 years ago, I'd done many of these operations without serious trouble. She had severe headache. She said she wanted the operation after I had discussed it with her. So I operated. It went very well. She went home after 2 days, which was very good. And she came back a week later very ill. It's too complicated to explain, but I couldn't understand what was going on. I'd never seen this quite before. I got a brain scan, which, hang on, I've gone the wrong way, haven't I? And the brain scan, the CT scan, I looked at it and I was so worried, I was so puzzled. I couldn't see what was directly in front of me, which was that the cerebellum is squeezing out and there is black stuff in front of the brainstem. That is a life-threatening infection called a subdural empyema, which I've never seen before. I never saw again. But I couldn't see it. I was so anxious, I couldn't see it. And I hesitated before reopening the wound and clearing out the pus, the infection. And she was left terribly, terribly disabled, completely disabled by my delay of 24 hours. If I had shown that scan to a colleague who would have been detached, would not have had my optimism bias, he would have said, Henry, look, there's a serious infection there. So I remember that case because it showed me just how, you might say, stupid I could be. And that's not because I'm a bad doctor. That's because I'm a human being. And we easily make mistakes. And the tragedy for us as doctors is the consequences of our mistakes can be terrible for our patients. That is the WHO surgical checklist, which was introduced, 25 years ago in my hospital. It's a checklist where the theatre staff confirm the side of the operation, you don't remove the wrong leg or things like that, you make sure you got blood cross-matched. Sensible idea. But I was opposed to it. I felt threatened by it. How stupid could I be? So I was complaining in the operating theatre when the list was introduced. And my anaesthetist then reminded me that once I had started a craniotomy on the wrong side of the head. Patient hadn't come to any harm. It's easily done, but for complicated reasons. But so I had to admit, yes, well, I suppose it is a good idea. But how could I be so stupid? The answer is we don't like to think we make mistakes. When you walk into the operating theatre, you don't want to think, oh dear, have I remembered everything? What might I do wrong? And the need for self-confidence can blind us and make us stupid. Now that's a very good book, not about medicine. It's about mistakes and the way progress in so many areas of life, aviation, medicine, war, is based on making mistakes, but learning from them. And that's how we make progress. And Syed, the author, illustrates this with stories about various terrible aeroplane crashes. That was a Korean Airlines Boeing jumbo jet coming into land in bad conditions. The ground radar was being serviced and was not working. So the pilot was having to fly by his own estimation of how high up he was coming into land. And on the black box tape recorder, you can hear the co-pilot saying 200 meters, 150 meters, 100 meters, 50 meters, and they're all dead. So what was the conclusion? Because the pilot thought he was higher up than he was. The pilot was struggling, he was under stress, and he wasn't listening to the co-pilot. What conclusion did Korean Airways derive from that? Well, it's called cabin crew training. Pilots should listen to their co-pilots, and co-pilots should speak up. And it's exactly the same principle as I was talking about with the mistakes I mentioned to you just a moment ago. Now, medical decision-making. This is the difficult bit of medicine. Yes, you need to study, you need to learn skills. I'm told you have a wonderful simulation lab here, which I'm looking forward to playing with tomorrow. And as I said before, you balance the risks and benefits of treatment against the risks and benefits of no treatment. But the important point about this is that these are probabilities. They are not facts. We have to estimate how likely is it, like saying, will it rain tomorrow? This is like medical decision-making, it's probabilities. And the problem with probabilities is our judgment of probabilities is often wrong, because that's the way our brain works. And there's a wonderful book by the late Danny Kahneman, you may have heard of it, called Thinking Fast and Slow, which is all about this problem, that when we have to estimate probabilities, our brain is wired to make shortcuts. We will make our judgments on the basis of previous experience, not necessarily on a rational assessment of risk and benefit. And there are many of these cognitive biases. I will not go into all of them, but there is, for instance, one called the halo effect. Halo is what saints, fiat, have around their head, a golden ring. If you like somebody, or you think that they're very good at one particular thing, we easily overestimate their ability at doing other things. I mean, that's a problem I had as a teacher. If I liked my surgical students, sometimes in the early years of my career, I made serious mistakes when I gave them too much to do. I overestimated their ability to operate because I liked them as people. Just yesterday, I think it was the day before yesterday, I was lecturing in Lviv. And this man is a great, great scientist, Svante Paabo, who is Estonian-Swedish. You may have heard of him. He is the world expert on ancient DNA. And he and his team in Germany have established the genome of Neanderthals. And he has a Nobel Prize. And I was having lunch with him in Lviv, and he said, the trouble with having the Nobel Prize is that everybody thinks I know about everything. All I know about is Neanderthal DNA. But because I have the Nobel Prize, people think I'm super clever, and they want my opinion about many things I know nothing about. And we also see that problem with all these wretched American billionaires. They were smart with computers, They were lucky to get into the internet in its early years. They've all become very, very rich, but they're not very, very clever, and they have no right to be dictating politics or economics or the world in the way they have so much influence now in America, which they shouldn't have. Just because they're rich does not mean they're super clever and understand what's important in life. You as doctors will understand better than they will ever understand what's important in life. And you may have come across this famous invisible gorilla. I can't show you the video because it's copyrighted, but people have shown a video of people passing a ball, and they're asked to count the number of catches, the number of times people in the white t-shirts catch the ball. And then in the middle of the video, a man walks into the stage in a gorilla suit and goes like that, and you can see the gorilla suit there. This is an amazing fact, but true. 75% of people do not see the gorilla. They're so busy looking at the people in white t-shirts. And as doctors, we're very busy, we're stressed, we're often doing many things at the same time. It is easy to make mistakes again if we trust ourselves too much. We must always be very careful, and as Kahneman says in his book, Thinking Fast and Slow, we must make decisions slowly and not in a hurry. So we must learn to be self-critical, but not lose our self-confidence. We all make mistakes. We all feel bad about making mistakes. But it's important to recognize this is normal, this is natural, this is part of being a human being. The challenge is to learn from mistakes rather than hide from them and deny them. Now, important fact number 2, which is related to important fact number 1, is there's nothing more frightening for a patient than a frightened doctor. You as students, are not responsible for what happens to patients, so you can have a fairly relaxed, friendly relationship with them. But once you're doctors, you will be doing painful, unpleasant, frightening things to patients. You are responsible for them, and you must not show them you are anxious, and we often are anxious, particularly when we're young doctors. But even at the end of my career, if I had a difficult operation to do, I would feel anxious beforehand. It's very important. If you're not anxious, you will not be careful. Anxiety is a very important part of being a doctor, particularly a surgeon, but not so anxious that then you can't do the work. So my wife is a very well-known English writer and anthropologist. She wrote a big world bestseller about why the English, like me, are rather strange from an anthropological perspective. And she has Crohn's disease and is often in hospital. And she tells me once she was in hospital having her blood taken, and the young doctor left a long line of bruises and pinpricks up her arm, and he couldn't get any blood out. And then he said to her, "I'm terribly sorry, I haven't really done this before," which of course was a terrible thing to say. This is very frightening. My wife now felt she was in the hands of a totally incompetent doctor. What that young doctor didn't understand was he was facing an ethical problem, which we all face. At what point should he have said to my wife, "I can't do this, I'll go and ask for somebody more experienced to come and help take your blood"? And you'll face problems like that throughout your career, where you have to decide, can I do this, or should I ask for help? And there are 3 ways. We have to hide our anxiety from patients, because it's horrible for patients if their doctor is frightened. You can hide it by not having it in the first place, if you're a psychopath. Psychopaths do not have empathy. But most doctors are not psychopaths. The sort of stereotype of surgeons, particularly neurosurgeons, is they're psychopaths and are completely cold. But that's not true on the whole. You can hide it from others, disguising it. But the most effective way of hiding your anxiety from your patients is to hide it from yourself. Denial at an unconscious level. And we all do that. We have to believe, to some extent, we really are as good as our patients desperately hope we are. But we must not let that distort our judgment, if possible. Trivers is one of the great figures of evolutionary theory. He was one of the originators of the selfish gene theory with the English geneticist Bill Hamilton, about why selfish genes can produce altruistic organisms. Because we are altruistic, we care for other people, even though our genes don't. And he wrote a very funny book called Deceit and Self-Deception, in which he tried to work out why do human beings have this great ability for self-deception. We all think we're better than we are. We all have high self-esteem when it's not really fully justified. Because he said in nature, deception is everywhere. We are all part of a food chain, either as predator or as prey or as both. And he said the answer is why lying, deceiving other people, has been selected by evolution, he says, is because it makes us better liars. If you try to deceive people, if you believe the lie yourself, it makes you much more successful. And you don't have to look very far afield to see. I know Boris Johnson is a hero in Ukraine, but he's not a hero in England. So self-deception is an important skill in many ways, but it must be kept under control. And then there's another problem related to this, particularly for surgeons, particularly perhaps for men, for male surgeons. I'll come back to the question of female surgeons in a moment. You know your Walt Disney and Snow White and the Seven Dwarfs and the evil stepmother who looks in the mirror every day and says, "Mirror, mirror on the wall, who is the fairest of them all?" Until one day the mirror says, "Snow White is more beautiful than you are." And she gets very jealous and tries to kill Snow White. Surgeons are a bit like that. I certainly was. We all know, particularly when we're at the beginning of our careers, there may be somebody else who's better than I am. We have to tell our patient, "I'm the man for the operation. I'm the best man to do it." But if there's a little voice in the back of our head saying, "Well, actually, there's another surgeon who's more experienced than I am." And that's a problem we all face in the early years of our career when we become independent surgeons. It's difficult. The answer is, ideally, is teamwork. You should work with that better surgeon to become better yourself. But there is this deep fear that other people might be better than me, which explains a lot of conflict, jealousies, fighting that goes on between doctors, particularly between surgeons, which is made worse in countries like Ukraine, where all doctors depend upon what we call informal co-payments from patients, because doctors are paid so little by the state. So the doctors are in economic competition as well as just professional competition. And of course, as doctors, we have great power over our patients for a short time, even more so perhaps as surgeons. And as the famous 19th century English historian Lord Acton said, all power tends to corrupt, and absolute power corrupts absolutely. And we must not allow the power we have over our patients to corrupt us, corrupt our judgment, and corrupt our humanity. So teamwork is terribly important. Firstly, my colleagues don't have my cognitive biases. They will help me make better decisions and make fewer mistakes. We learn from each other. If my colleagues can learn from my mistakes and my successes, if I can learn from them, we will all become better doctors. And finally, life as a doctor can be very stressful, and particularly in Ukraine at the moment, particularly in the East. And the support of your colleagues, only your colleagues understand how stressful the work can be. And if you're part of a good team, this is hugely important for your mental health, for your resilience, for your ability to deal with the sometimes overwhelming responsibility we have for other people's lives and sometimes for the terrible things we have to bear witness to. I'll skip that slide, I think, it's too complicated. So good teamwork is not just about everybody agreeing with each other, all being friendly. It's about constructive criticism, where we criticize each other, but in a constructive way to make things better for our patients. So, yes, you might say, it all sounds very good, but how can a medical student become a good doctor in Ukraine, where everything is so difficult? You had the pandemic, you had the war, and there's the corruption as well. So how can one be a good doctor? How can one learn? Well, it's difficult is the answer. But what I'd say to you is, first of all, compared to my generation, with AI and the internet, there is an amazing amount of medical information, some of it very good, at your fingertips. You don't have to go and look in big books or go to libraries. So the information is all there if you know where to look. The best way, I think, of becoming a good doctor is to be what is called in the educational literature a self-starter. You motivate yourself to solve problems. And the foundation of that is to see patients. Yes, we learn all this theoretical anatomy, physiology, pharmacology, yeah. But if you actually see patients, you see a patient with a problem and try to work out what is wrong with them, and then apply the relevant anatomy, physiology, pharmacology, pathology to that particular problem. It is much easier to learn medicine that way. You'll then, when you are asked, what are the causes of leg pain, rather than reading a long list out of a book in your head, you'll remember patients you saw and spoke to and understood the basis of their symptoms. Hang on, sorry. So listening to lectures and learning long lists and facts, in my opinion, although it's a traditional part of learning medicine, is actually not a very effective way of really learning and becoming a good doctor. Medicine begins with patients and ends with patients. You'll find learning medicine much easier if you base your learning on real patients, applying your knowledge, your theoretical knowledge, to practical, real problems. So if you think about cardiovascular disease, you'll remember patients you've seen who were breathlessness at night, what's called paroxysmal nocturnal dyspnea, or pain down the left arm from ischemia, rather than a long list of abstract facts. And then you'll understand the symptoms in terms of the theoretical stuff. So the more you see patients as medical students, the better the doctors you'll become. If you don't like patients, if you don't like talking to them, if you're not interested in them, well, maybe medicine is not for you. For instance, if you see a man with leg pain, you can then research the causes. Is it neurological from a trapped nerve, or osteoarthritis in the hip, or vascular from narrowed arteries? You'll remember the patient and how they presented and what symptoms and signs they had. And then there is a course, I don't know if you have an equivalent in Ukraine, what is called the diagnostic sieve, for which there's an English mnemonic of vindicate, and you have this list of all the possible causes of any clinical presentation, vascular infection, neoplasm, degenerative, and all that. And you work it out practically on the basis of patients you've seen and talked to and understood. A brief note, this is all for women. I gather that 75% of the medical students here are women. The good news is serious scientific research shows that women make better surgeons than men. The men won't like that. But there was quite a good paper on tens of thousands of operations published recently, showing that a year after surgery, patients operated upon by women had lower complication rates than patients operated on by men. Why? I don't know. I leave you to think about that. So I'm often asked, what would your advice be for doctors of the future? Well, first of all, the old Greek knothen se auton, know thyself, understand your limits, understand your cognitive limitation, understand the concept of cognitive biases, and why teamwork and other people are such an important part of being a good doctor. And you'll note that man is lying on a bed of nails. It is painful. It is painful to be self-critical, but it's very important. And secondly, that's that one. ask for help. To ask for help is not a sign of weakness, but it's a sign of strength. It means you understand you have reached your limit and you need somebody else to help you. I can think of several operations I did when I was younger, a long time ago, where I should have stopped. I should have asked a more senior surgeon to come and help me, and I didn't. And as a result, the patients came to terrible harm. It's very difficult in the middle of an operation to realize you're out of your depth, but it is a very important skill to have. So it is wonderful to be a doctor, despite all that. Yes, you have to work and study hard if you want to be a good doctor. But that would be much easier, in my opinion and experience, if you base your study now as medical students on seeing and caring for and relating to real living patients and finding just how interesting and fascinating they have. They all have an interesting story to tell. And good, rewarding medicine ultimately is about caring for patients, not just being a technician or a businessman. And finally, all I can say is Slava Ukraini.
Yeah. Dear Professor Marsh, we want to show our deepest gratitude for this incredibly motivated lecture for all of us, for students, for residents, and for our teachers. And we would kindly ask you to give answers to all of the questions that can be raised here. Дорогі учасники, ми запрошуємо вас на сцену для того, щоб по черзі, відповідно, для того, щоб поставити питання професору Маршу. В порядку живої черги, так.
Yeah.
Hi, Gенrі Marsh. I'm a student of Bukovinian State Medical University. And my question is, how should a surgeon deal with the internal feeling of guilt when they did everything flawlessly and according to protocol, but the patient still got worse?
Well, I mean, there are two things. One, you have to think, am I absolutely certain I would do exactly the same next time? Is there anything I could do differently because this operation went badly? And secondly, talk to a good colleague. Discuss it with a colleague, both to relieve your feelings and also to get an outside opinion. But if you bottle it all up in yourself, it makes it more difficult. Yes, we all feel bad if a patient comes to harm, but we have to accept that. But this is inevitable. It does not necessarily mean I'm a bad doctor. It means I'm a human being, and the challenge is to learn from it, discuss it with colleagues, think, what will we do differently next time? That, in theory, is what happens at what are called morbidity and mortality meetings, if they're conducted well, when in a surgical department every month, the surgeons, all the surgeons, both senior and junior, are supposed to discuss bad results and discuss what might have been done, what should be done differently next time. But whether those meetings work well or not depends very much on leadership and the relationships, the personal relationships between the senior doctors at the meeting. But they are an important part of surgical practice.
Okay, thank you so much.
Oh. Okay.
Hello, Dr. Marsh. I would like to thank you for the lecture. Also, I would like to ask you a question. What were your first emotions when you first operated as an attending neurosurgeon, and how did you?
Well, I'd already done an awful. The English system then was that as a trainee, I did a lot of operating on my own, so that becoming a consultant, the actual technical side of the operating felt fine. But what was difficult was that suddenly total responsibility for the patient was on my shoulders. I'd clipped many aneurysms, which is one of the most difficult, delicate operations in neurosurgery. I'd clipped many aneurysms as a trainee on my own, but the first one I had to operate on as a consultant, I was shaking like a leaf because I was in charge before my boss ultimately was responsible for my mistakes. But once you're a consultant, you're responsible for your own mistakes. And that took a while to come to terms with. The responsibility is difficult.
Thank you.
Huge thanks for your presentation. It was a great pleasure to hear it, and the fact that I've been in Spain and I've been experienced a lot of neurosurgeons, and I was like, okay, this is so inspiring, and I would like to maybe try it in the future. And I would like to ask you, what is like the key point to understand, okay, I want to do it. I won't be afraid of shaking in my hands and something like that.
Well, I think on the whole, if you want to be a surgeon, your hands don't shake, because you just want to use your hands. But I think it's important, there's a lot of mythology about neurosurgery. A lot of mythology is not very sophisticated. A lot of neurosurgery is not very sophisticated. There are a lot of damaged patients we can't help, head injuries, trauma. I mean, with the war, 75% of death is from head injuries, or usually. But neurosurgery can do very little to help that. You need to work in a neurosurgical department as a junior, as a nurse or whatever, to see what it really is like. Neurosurgery has a very high failure rate. There are many patients we can't help, and not everybody can cope with that. So you need to be, if you want to be a neurosurgeon, you really need to. It's not something to do as a sort of, maybe I'll do it, maybe I won't. You have to do it. It's almost a compulsion.
And the second question is how to cope with that thing that you understand, okay, that's a mistake, that I have done it, and it's absolutely my fault. How not to bully yourself and keep going, like doing your work.
You just have to, is the answer. But if you have sympathetic colleagues you can talk about it with, and they'll say, look, I've made terrible mistakes as well, it makes it a bit easier to carry on. But if you can't cope with it, then you shouldn't be doing the job. You shouldn't do the work, because you will make mistakes, you will have bad results, and you have to accept that.
Yeah, trying to be hard. Thank you. Huge thanks.
Okay.
Good afternoon, Professor Marsh. Thank you so much for the lecture, actually, and incredible opportunity to ask you a question. I'm actually a pharmacy student. I'm a junior, and so I'm not really related to neurosurgery, But I'm interested that in your lecture you've said a lot about the burden of the surgical decisions, and in your books also. And so, as a pharmacy student, I'm interested. Looking ahead at the rapid advancement of biotechnologies, do you think that it will be possible in the future, like basically to replace surgical interventions with pharmacotherapy, or do you think that it won't be possible?
Well, the future is hard to predict, but on the whole, progress in neurosurgery is to make neurosurgery unnecessary. I became a neurosurgeon because I fell in love with aneurysm surgery, where you put these microscopic clips on the blood vessels in the middle of the brain. It's like sort of bomb disposal work, because if the aneurysm bursts, the patient will probably die. But then over the last 20 years, that has become almost completely redundant because of interventional radiology using catheters from inside the arteries. So although paradoxically, I'd want to operate, but actually real progress in neurosurgery is to make operations unnecessary. There'll be some things which won't go away, age-related spinal problems. That will not be solved by pharmacology, because we can't solve aging, because these problems are due to getting older. Some of the solid tumors, it's very unlikely surgery will be replaced. But the problems like the malignant brain tumors, the glioblastomas, surgery is not a very good solution to that. So if we make progress there, it almost certainly will be some kind of drug therapy. But there are big problems of treating the brain with pharmaceuticals.
So there will be like basically a brain injuries or a physical nature of the brain injuries that won't be able to treat by...
I doubt it. But you never know. I like to quote the example, you know the GLP drugs for obesity? Do you know where they were discovered? The Gila monster, a lizard with poisonous venom. Some mad scientist was terribly interested in looking at Gila monster, G-I-L-A, Gila monster venom, and it turned out they're the GLP agonist, which lasted a week as opposed to the human version. So it's a good example of how abstract curiosity research can produce extraordinary things. So we never quite know what will happen.
Okay, thank you so much.
Hello, sir.
Hi.
I'm a fifth course student who have just finished my course. Firstly, thank you for visiting our university, and my greetings to Vice Rector and Rector, sir. Sir, my question is being a medical student and coping up with all the hardships and the struggle we have to go through by studying day and night. And in the future as well, as a medical practitioner, it will be quite burdensome to go through all the duties of which will be lasting for hours and hours. And my question is, sir, what are the habits as a student or a medical student and becoming practitioner that I can develop so that I can cope up with all the stress and keeping my hobbies alive along with my medical practice?
Well, I agree there can be a problem of lack of time, but we know that the two crucial elements to a healthy life is a good sleep and physical exercise. You should always try to find time to exercise and try to sleep well. If you try very hard to sleep, you won't, of course, but that would be my advice. Don't always try to get a good night's sleep and plenty of regular physical exercise.
Okay. And being a very busy neurosurgeon, how did you cope up being your habits, sir? You're even a
Well, I sacrifice my family basically, which is bad. I think if you're married, you need a sympathetic husband or wife because it is very demanding. It's bad for family life.
Okay. Thank you, sir. Thank you.
Dr. Marsh, firstly, let me say thank you for this gorgeous lesson. And my question is about operations. As we know, a situation in the operation room can shift in a split second. And what is the best way to concentrate for a surgeon and to make decisions in the extreme pressure?
Well, first of all, you always need to be prepared. You need to have worked out in advance what needs to be done, what might go wrong. So think carefully. That means anxiety, worrying, trying to think in advance. If there is a problem, am I prepared for it? I found when operations started going badly, I usually found I just became terribly calm in an odd sort of way. I was worried something might go wrong, but once it actually happened, you then just have to fix it. And it's almost sort of automatic, takes over. So it wasn't, I can only think of 2 or 3 times in the whole of my career where I really got completely flustered and lost and didn't know what to do next. But the critical thing is good preparation. And that's partly a question of experience. You've done the operation before, so you know what the possible problems might be.
Thank you for your answer.
Hello, Dr. Marsh. I'm not a student, actually.
You look a bit old. Yes.
But our students are nice,
Yes.
aren't they? Okay, my name is Andrei. I am an obstetrician, and I'm not going to talk with you as you are a physician. I'd like to express my gratitude. I'm your reader, long-time reader. I'd like to express my gratitude to you as a writer. I'm an ordinary reader in very unordinary conditions. How did it happen? I do not speak about this very much publicly, but I have experience as a combat medic in the armed forces of Ukraine. I spent there 1.5 years, and in some critical circumstances, sometimes you dig very deeper into your mind and you search for something which helps you to cope. And one of things, actually there are good books, fictional and non-fictional. And I must admit that among non-fictional books I could remember in very tough circumstances were your books. And
I'm honored.
I wish I could, yes, I wish I could to say it to you personally. Probably not publicly, but this is absolutely exceptional books. These are very humanistic books, very inspirational books. And I'm, as a medical teacher, also I'm very grateful to you because they're very inspirational. And okay, I have got a question.
Thank you.
Besides, okay, do you have some favorite book? Besides of that books you wrote by yourself. I mean fictional book, not fictional.
I don't read very much fiction, and I read a
Probably
lot.
from your childhood or
Well,
probably
well,
school
childhood,
age.
it was
Yeah.
Tolkien, you know.
Yeah, really?
The Hobbit. I particularly like The Hobbit, actually, the first of the Tolkien books.
We all love Hobbit here. That's true.
A book I reread recently, which I think is a remarkable book, is Stanislav Lem's Solaris, the science fiction novel. That's, I think,
Stanislav Lem.
is a profound book. I reread that recently and thought what a remarkable book that is.
And again, I would like to express very strong gratitude to you as an author, as a person who wrote all this experience and described, and they are very honest books.
Well, it's a
They're
delight.
absolutely honest.
It's a pleasure to be here.
And they're exceptional. Thank you so much for what you have done and what you have done for Ukraine. Thank you so
very
much.
Thank you. Thank you. That's very kind of you.
Dr. Marsh, hello.
Hello.
It's a great pleasure to meet you. I wanted to ask you a kind of philosophy question, maybe. Well, if you could prepare all the future doctors for one of the hardest and most difficult thing they will have to face in the future in their career, then what would it be and how to cope with it?
It is if you've made a terrible mistake, the patient's come to terrible harm, and you have to go and talk to the family or the patient afterwards. That is very, very painful. To say sorry is really difficult. Yeah. And as a neurosurgeon, I can think of some patients where they were fine, or more or less fine, before the operation, and things went badly. It wasn't necessarily I made a mistake, but they were left terribly damaged. And then you have to go on the ward rounds every day and stand at the bed and look at this person whose life you have ruined. Death is easier. When the patients die, they disappear. But when you leave them with severe brain damage, they're there to haunt you for a long, long time. And that, I think, is... But that's a particular problem with neurosurgery. I don't think it applies to many other medical branches, thankfully. But if you go into neurosurgery, you must be prepared for that possibility.
And how to cope with this emotional burden?
Well, I mean, when you're a young surgeon, it's very difficult. As the years go by, rationally, I would think, well, first of all, I had fewer bad results on the whole as the years went by, but also I had many, many patients I'd helped, and rationally, I knew I'd helped far more patients than I had hurt. But if it stops, and I'd tell my colleagues or juniors if they were upset about a bad result, I'd say, look, it would be even worse if you were not upset. The fact you're upset means you're a good doctor and you'll try to do better next time and learn from it. So the pain is a necessary part of being a good doctor.
Yeah, I totally agree. Thank you so much for the answer.
Hi, Dr. Marsh. First of all, I would like to thank you for coming to Ukraine and our university. Thank you also for your awesome lecture. And my question is, how do you accept the fact every day that sometimes even an absolutely correct medical decision does not save a life?
Basically because I loved the work. I loved operating, I loved neurosurgery, I loved my patients, and I always went to work in a state of controlled excitement. Every day was exciting. I knew that when I went home in the evening, I might feel terrible, but I might also go home feeling wonderful. It's a very up and down life. But as of all surgeons, I just liked, operating is not work. Outpatients can be work, but operating is enjoyment, even though it's so horrible for the patients. So I loved the work, and that kept me going. I never once regretted my decision to become a doctor or a neurosurgeon.
Thank you so much.
So, hello. First of all, as many people before me have already said, I'd like to thank you for this beautiful...
De nada, as they say in Spain.
Yes, thank you. So, my question is, as a student in the operating room, what should we do to absorb as much knowledge and information as possible?
Well, actually, watching operations doesn't tell you very much on the whole. I mean, yes, it's always interesting to watch, but I'd come back to what I said in my lecture. The important thing is talking to patients. And yes, if you talk to a patient and then see the operation, that is a good idea. But you learn operating by doing it. Just watching an operation does not tell you very much. It's interesting to begin with, but it's a practical skill. You learn it by doing it, and if you have good simulators, as I'm told you have here, and that can help as well.
Well, then, does it even make any sense to attend such an operation as a student?
Well, if you're interested in surgery, you probably should attend to see if you like it, if that's for you. Mm-hmm. But if you're not interested in surgery, there's probably no great benefit to going into the operating theatre, other than a few times to begin with.
Okay. Yeah. Okay. Thank you.
Hello, Gенrі Marsh. First of all, I would like to thank you for such an informative presentation and lecture. And actually, I have two questions for you. The first one is, for instance, when you operate, you're navigating a brain, which is like the physical seat of the soul. And after thousands of procedures, do you still maybe view our brain as a person? Or has the endless precision turned it into another biological machine?
When I did my first operations on a brain as a young doctor, I thought, this is amazing. This is everything. This is life, the universe, personality, feeling. But as the months and then the years go by, it's just matter. You do not have lots of profound philosophical thoughts. But you must never forget that the brain is incredibly delicate, and you must be very, very, very careful. The brain does not heal in the way that skin, muscle, bone will heal and knit together. The brain is very easily damaged. But in terms of philosophy, no, after the first sort of big thrill and kick of operating on a brain, I no longer had philosophical thoughts. Having said that, though, I remain absolutely fascinated by neuroscience and the fact that as a neuroscientist, I accept that everything I'm thinking and feeling in my head and everything you're thinking and feeling is a physical process. And when you think about it, that is an extraordinary thought. And we've not really come to terms with it. And then there's always rubbish being spoken. People saying AIs are conscious, computers will become conscious. It's complete rubbish, but it's become quite an important question. If people claim an AI is conscious, they'll say they have legal rights, you know. So we don't even begin to understand how physical matter gives rise to the most interesting thing in the universe, which is me, my consciousness. We know nothing about that. The laws of physics have nothing to say about that, and I find that an extraordinary thought.
That's true. I really consider your thought as I thought it myself. Also, I would like to ask you, you've often argued that the hardest part of neurosurgery is knowing when not to operate. Yes. And how do you reconcile your technical ability to save a life with a moral way of potentially condemning someone to life they would find unendurable?
Well, because you always have to say, what are the risks of the operation? What are the risks of not operating? And sometimes the risk of operating is greater than the risk of doing nothing. In fact, I was talking to my colleague, Dr. Mizak. He had seen a patient with a very, very difficult abnormality in the middle of the brainstem, something called a cavernous hemangioma. She was in her 40s. She had had a bleed, a hemorrhage as a teenager, like a mini stroke, had made a good recovery. And then 30 years later, she had another hemorrhage, from which she made a reasonably good recovery. And we do not have the data, the information about this particular type of abnormality, a cavernous hemangioma. We cannot predict whether there'll be another hemorrhage again or not, but it certainly could be serious, it could kill her, it could be a devastating stroke. But the fact of the matter is she was born with this, she has had it for 40 years, and has had 2 hemorrhages from which she made a good recovery. And I saw the brain scan, and it was clear to me, in my opinion, that surgery was impossible. You'd have to make an opening into the brainstem, which would actually do more damage. And I told my colleague, I said, look, it is better to do nothing. If she is lucky, she might die from something else in 20 years' time. But she saw another surgeon in Kiev who operated, and he operated because the patient wanted the operation. Now, and her daughter didn't want her to operate. My colleague had advised against surgery, another surgeon had advised against surgery, but the woman wanted the operation because she said, I can't live with the thought I might have another hemorrhage. If the surgeon who had operated, it was all about the way he spoke to her. If I saw patients like this in England, it's a very rare problem, but I did sometimes see patients like this, I would say, look, you might have another hemorrhage, but it's very unlikely. I don't think you will. I can't promise that, but I think it's going to be all right. Go away, lead a normal life, and with a bit of luck, there'll be no more problems. She then probably would have gone back, she was okay, and lived a fairly happy life. But clearly the surgeon who operated, maybe because he wanted to operate, frightened her, he operated, she is in a coma on a ventilator now many months later, which is what I would expect to happen. So sometimes with these critical decisions, the way you talk, the expression on your face has a life or death meaning, is one of the extraordinary things about being a doctor.
Okay, thank you so much.
Okay.
Dear Dr. Henry Marsh, thank you so much for your presence here today. We really appreciate your support. I'm doing residency in surgery. This is my second year, and I would like to ask you how you prepared for surgeries. I mean, not only professionally, but also mentally. Like, what is your routine, and how do you focus and get ready yourself to
Well, first of all, a good night's sleep is important. Except in the early years, you will be anxious before operating. But as you become more experienced, on the whole, the anxiety becomes less and it becomes easier. But you should never lose the anxiety completely. It's important to be a little bit anxious to make sure you prepare yourself properly. I think that was the main thing, a good night's sleep, to be relaxed, to have thought about the case, looked at the notes again, felt this is the right thing to do, worked out what you were going to do to be well prepared.
Well, thank you. But what are you doing during an operation and you have some complications, for example? How do you make decisions, like what to do?
Well, you kind of switch on to autopilot. You know, it's like if you're driving a car, it almost crashes. You start working at an unconscious level is the answer. And the more experienced you are, the better the unconscious reaction will be. It's pretty unusual in surgery to have a sort of sudden disaster like that. And usually there is a solution to it. Obviously, you've got to keep calm. But I think most of us do. We might sweat and shake a bit, but you have to fix the problem. You can't just say, oh, I give up and walk out of the operating theatre.
Well, thank you so much.
Okay.
Dr. Marsh, my question is, throughout your life you have trained a lot of young doctors,
yes,
students, so what qualities do you look for to make them your favorite?
Well, I had no favorites, but the ones who worried me, I've trained hundreds of doctors, the ones who worried me, the ones who were not anxious, were too self-confident. They were the ones who caused serious problems for me.
Who were anxious?
They were not anxious.
Who were not anxious.
They were not anxious enough. They believed in themselves too much. They were too self-confident. You know, I didn't want them to be nervous wrecks, but thinking back, those are the ones where I had problems, when they thought they were better than they really were,
okay, so
and were not
a
anxious.
little bit of fear and anxiety is important.
It's very important. It's very important, because what we do is so serious, you know.
Yep.
If you do an operation, particularly in brain surgery, if you're not worried, you're a bloody idiot. You know? It's so serious.
Okay, thank you so much. Thank you.
And when you see senior surgeons operating, they will hide their anxiety, you know. They'll appear very calm and cool, but I promise you inside, they usually are not. And that I know is why particularly my first book has been so popular, because it's unusual for a senior doctor to say, actually, I get jolly anxious and I make mistakes. It's kind of reassuring, you know.
Okay, thank you so much.
Okay.
Hi, Gary Marsh. Thanks for coming. It was very interesting and very important for all of us. And I have two questions for you. First, can you tell more for us why did you stop working and talking with eager curious? Because unfortunately, there are no detailed information in your book about this.
Yeah.
Or maybe I...
Well, the answer is I came to Kiev, or Kiev as it was then, almost by chance. In 1992, an English businessman was hoping to sell British medical equipment in the newly independent Ukraine, and because there was a famous Institute of Neurosurgical Research in Kiev, he thought, if I take an English neurosurgeon to give some lectures on modern neurosurgery, it'll be good for goodwill and sales. It's complicated to the extent that before I became a doctor, I had studied politics and Soviet politics at Oxford University. I was going to become a Kremlinologist, believe it or not, and then instead became became a doctor years later. And I met Kurelets, and Kurelets was in the emergency hospital in Troyeshina. And he really was the only doctor I met who said, look, everything here is terrible. And the conditions were absolutely terrible in Ukrainian hospitals after independence. And I said, well, I think I can help you. So I started going to Kiev from London with second-hand instruments. Nobody was using operating microscopes in Ukraine in the early 1990s. So I trained him up how to do microscopic spinal surgery. And then he became more and more ambitious, and we started doing brain surgery. And the operations got more and more difficult. And I got a bit reluctant, and I felt I wasn't sure I should be encouraging him to do that. And then I learned that actually, particularly one patient we'd operated on had died weeks after the operation. And he'd never told me. And that for me was really the end, because if there's anything I believe in, it's being open. And if you shouldn't do an operation if you can't cope with the complications. If he'd telephoned me and said, look, Henry, this girl's, things have gone wrong, I would have cancelled my operating in London, got on the next aeroplane to come out to try to help. So it took me a while to realize that, but it's an example. He was a great surgeon, a remarkable man, and very ambitious, very dynamic and determined. But it was a bit of an example of power corrupting, you know. He became a bit too self-confident, and he was taking on operations I felt he probably shouldn't. So I very reluctantly felt I had to stop working with him, and I work with, I no longer operate here now, but I now lecture and meet other people.
Thanks. And another question, it's very personal, my question. Would it be a great idea to become a neurosurgery, start from neurology residency? Because in this year I graduate from university, and I hope that next year I will become a neurological resident. Yes. And it's correctly to then continue as a neurosurgeon.
Well, I think that's a good idea. I mean, the diseases neurosurgeons deal with are very different from the diseases neurologists deal with, but what I found, I became a brain surgeon because I found the brain so interesting as well as the operating, and I still find the brain very interesting. So I think doing neurology first is not essential. You can be a good neurosurgeon without doing neurology. I think it's a good idea. I would encourage you to do that. It will broaden your understanding of your patients.
Thank you.
Okay, good luck. Last question? Or is it all done?
I guess so.
Okay.
Actually, that would be the two last questions from me. The first, I want to say thank you so much. And my first question is, how do you calm yourself down after a very tiring and exhausted a day?
Well, I shouldn't say this, but gin and tonic is the answer.
So
but in moderation, in moderation.
Totally agree with you and understand. And the second question is, I'm the sixth-year student. This year I finished studied at university, and my second question is, how can I, as a young doctor, learn to live with mistakes I've already made? Because I'm pretty sure that mistakes will be in my future career.
Well, the answer is try to learn from them, you know, and accept we all make mistakes. Don't beat yourself up too much. And if you remember a mistake, think, well, what have I learned from that? What will I do differently next time? But it never leaves you. I mean, now that I'm retired, every day I will suddenly remember a patient where I think I failed. But no, you have to try to look at them in a sense, in a positive way, but they're learning experiences, even though they're painful. But they're necessary. If you never make mistakes, you're never going to learn anything.
Okay, and the third question, should I think about this before gin tonic or after?
Before the gin and tonic. I think after. afterwards, I think, probably. More seriously, actually, again, I said a physical exercise is very important. And a physical exercise is a very good way of relaxing. I used to run a lot. I run less now because I'm 76 and have a metal knee. But I still try to run and exercise. And psychologically, it's a very good way of relaxing.
Okay, thank you so much.
Okay.
Thanks a lot. I guess it was like our last question for today, and I think that we should give a huge round of applause for Dr. Gенrі Марш. And I would like to continue our event, and I would like to invite our honorable rector to the stage. And we would like to present a certificate of appreciation to Dr. Gенrі Марш for the lecture given to students and staff at Bukovinian State Medical University for his significant contribution to the professional development of future doctors, for promotion of medical science, and for inspiring the younger generation to strive for self-improvement and dedication to their profession.
Thank you, Gенrі Марш. I very appreciate it. I want to say thank you for incredible, inspiring, and profound lecture. It's a great honor for us that you are here. Thank you for your honesty. Thank you for your support of Ukraine. Thank you that you are here. And I hope you welcome back to our university. It will be a great pleasure. See you soon.
Thank you.
Thank you.
Thank you so much for your inspiring lecture. І ми запрошуємо усіх спочатку до спільного фото на сцені, а після того буде автограф-сесія із доктором Генрі Маршем із підписом його книжок. And first of all, we'll make a photo, until the autograph session.
Поки ми збираємося, я хочу ще вручити подяку Андрію Мизаку. Пане Андрій, можна вас? За допомогу в організації лекції. Але, шановні студенти, якщо ви відкриєте свої книжки, ви уважно прочитаєте, Андрій Мизак – це та людина, яка переклала всі книжки Генрі Марша на українську мову. Тобто, я хочу ваші оплески Андрію Мизаку за цю... А я хочу, щоб він сказав це.
Так, і ще мій батько в 1959 році закінчив ваш медичний. Він тоді називався Чернівецьким, зараз Буковинський. То для мене було дуже особливо привезти нашого друга, доктора Генрі Марша, власне, в Чернівці. Дякую вам всім, що прийшли.
індивідуальні. Так, індивідуальні і книжки.